Okay, it's my pleasure to welcome you all to this gynecology oncology segment session of the ZISOC annual conference. I'm Dr. Ernest Koza. I shall be standing in for Dr. Maxwell Chimina. So this afternoon, we will explore the frontiers in gynecology oncology, and this presentation which are coming will highlight the growing research capacity in Zimbabwe and in region at large as we continue to align with global cervical cancer elimination goals and strengthen our evidence-based oncology cancer practice. So at this time, I will take the honor to introduce our first presenter, Dr. Bothwell Takaingofa Guzha. He's qualified as an obstetrician and gynecologist in 2011 from the Royal College of Obstetrics and Gynecologists of the United Kingdom and College of Medicine, South Africa. After that, he acquired a diploma in minimum access surgery and has extensive experience in gynecological endoscopy surgery. He is also a board certified gynecological oncologist with a certificate from the College of Medicine of South Africa and holds a master's in philosophy from University of Cape Town. Currently, in his capacity, he is the lead gynecological oncology surgeon at the Parenyatwa group of hospitals. He is involved in running of the gynecological oncology services and chairs the oncology tumor board. And his main areas of research interests are gynecological cancer screening, prevention in low and mid-to-income countries. He is currently involved in several research projects with international collaborators like the IAC, and Dr. Bothwell Takaingofa Guzha is currently employed in the Department of Obstetrics and Gynecology at the University of Zimbabwe. I will take this moment in time to welcome Dr. Guzha.
Okay, thanks very much, Ernest, for the kind introduction. So this has nothing to do with my afternoon presentation. So when I presented in the morning, there was a glitch with technology, and I wasn't able to acknowledge the team that was helping us with the Awaken study that I presented in the morning. So I thought maybe I should just put this up before my presentation this afternoon. Okay. Okay, so this afternoon I'm going to talk about a study. I won't bother you with the full name. It's called the Easter Project. Okay, so those are the people who have contributed to this study, and we are in collaboration with the International Agency for Research on Cancer, as well as the WHO. No conflict of interest related to this talk. So I want to acknowledge these are all the people that we are collaborating with. There's University of Zimbabwe, NSV, our technical partners that are developing the artificial intelligence platform. There's IAC, WHO, University of California in San Francisco, where Prof. Chirenje is currently based, and the University of Central Lancashire, as well as our fantastic field teams, collaborators, and study participants. Couldn't have done this study alone without these 5 MDs in our department. I would say that I think they did 90%, maybe I should not say 90%, but they did 70% of the colposcopies. So I don't think this study was going to be feasible if I didn't have the support of these registrars, whom I thought I should acknowledge this afternoon. So that's the outline of the study. So what is the future of cervical cancer screening? I think I want to start by what's happening now is a patient goes and have an HPV test, which is WHO recommends. They ask to come back after about a week or two. Then they have a visual inspection to see if they've got a lesion. If they've got a lesion and it needs lip, then they are referred to another center to have the lip. But I think the future of what we are thinking is the future of screening is a woman walking into a clinic and they have spectroscopy-based HPV testing as a point of care. That will take less than a minute to get the results. And what we are looking to achieve is they have an AI-powered triage, which is capable of detecting CIN2 with a high sensitivity, specificity, and it guides the treatment by telling the clinician whether it's a type 1 or a type 2 transformation zone, and the patient gets immediately treated. This one-stop model will minimize loss to follow-up, and it's going to support the WHO 90-70-90 plan to eliminate cervical cancer. I won't bother you with these statistics. I think people have said them quite over again. So WHO is aiming to eliminate cervical cancer as a public health problem by the year 2120. And what are the benefits in human terms that we expect if we are able to achieve that? The median cervical cancer incidence rates will fall by 42% by 2045 and by 97% by the year 2120. This strategy averts more than 74 million new cases of cervical cancer and over 62 million cervical cancer deaths will be averted by 2120. And then cervical cancer will be eliminated. That means the threshold will be less than 4 cases per 100,000 per annum by 2120. We will all be dead. Time has started good, but hopefully this will be achieved when we are gone. I won't bother you about this. These are the problems that we have. Cytology has never worked in low and middle income countries for various reasons. And so the visual inspection has got a lot of problems with this positive predictive value. I've said that 10%, sometimes they've shown a PPV of about 10% when you use VIAC. So there is no doubt that the future for screening involves HPV testing. So what is AI? What do you when you talk about artificial intelligence cervical cancer screening? Artificial intelligence uses computer algorithms to recognize disease patterns in cervical images. So that means it's going to alleviate the shortage of skilled specialists. That means any Jack and Jill can just press the machine. They're told that this is CIN2+. They need to be treated this way, even if they are not. I'm just over dramatizing it. But that's what we are kind of like looking at. Reducing subjectivity and support nurses who run the screening program. It will improve consistency, speed, and scalability in cervical cancer screening programs. So basically, this study started in India, in Thailand, and basically they then realized that a lot of the cervical cancer occurs in Africa, and there was no data coming from Africa. Then they decided to expand the study to Africa, and then that's how Easter was born, and it's being run here in Zimbabwe. So the aims of this project was basically to develop further and validate two new technologies, screening for HPV with spectroscopy and using AI-powered in gynecology for triaging, diagnosis, and facilitating immediate treatment. So this phase has got we are done with the first phase, which we're aiming to build and optimize these diagnostic tools. And we were mostly training this artificial intelligence platform to be able to detect CIN2+. And the focus basically is to train spectroscopy and improve gyne system. I now moved into the, for us to progress to the first two, which we have done now, the spectroscope needed to have a concordance with HPV testing of more than 80%, and the gyne needed to have a sensitivity of 85%, and 80% sensitivity and 85% specificity to detect CIN2+, and they needed to be 90% image adequacy from the cervical image bank. And the field too, basically, we are now trying to evaluate real-world diagnostic accuracy and clinical applicability in Zimbabwe, and that is the focus of the study. The expected overall impact is to improve screening to a one-day model and minimize loss to follow-up and subjectivity that is associated with the current screening program, visual inspection. I won't bother with you with the flow diagram, the phase 1 and the phase 2 studies. We prevent, for us to do this study, we did a lot of monitoring and quality assurance. We've got all SOPs for every part of the study, including the laboratory and study monitoring. These SOPs were being actively followed during phase 1 of the study. So people who came for our cervical or colposcopy workshop, the chances to play with this device. That's the N-Gynet device. It's portable and ergonomic. It's got a camera sensor with LED, automatic light adjustments, intensity. It's touch-based screen with user-friendly interface. So basically, it prompts you and tells you what to do. And what is not there at the moment is the AI algorithm that is going to allow classification into low and high grade cervical cancer lesions, precancer, cervical precancer lesions, as well as cancer. And all these images can be stored in the cloud, and then they'll help for teaching and training more algorithm, more AI algorithms in the future. And then spectroscopy is a powerful technique for chemical analysis of a biofluid. Progress has facilitated low-cost spectrometers that can cost about 10,000 that are robust and portable, allowing for point-of-care testing. It's very easy to operate. You drop you just put a drop of urine on a slide, put it in the spectroscopy machine. It's going to cost less than $1 a test. I'm trying to do a study with NOMSA. In this moment, we are being said to do the full genotyping profile. You should pay something like $75. But this technology screening becomes very cheap, less than $1. Results are instantaneous, reproducible, and reliable. So basically, I'm just going to walk you through the findings of the phase 1 of the study. Bear in mind, I think the phase 1 was mostly to train the SI algorithm to detect CIN1. The study was launched in August 2023. So we're supposed to recruit 1,100 women, but we excluded 2 women because we could not identify their cervix when they came for colposcopy. The first one, then she confessed that she had had a hysterectomy before. The other one had had surgery, and the cervix was really pulled up, and we couldn't access it in the colposcopy clinic. So we were able to have valid HPV tests in 1,089 women. That's 99.2% of women that were enrolled. We enrolled from 2 clinics, Ipworth, 605 participants, and Mbare, which were 484 participants. The age distribution was adequate and representative across predefined cervical cancer screening age groups. HIV status was available for 861 women, and out of those, 20.6 women are HIV positive. And the good thing that also shows that our HIV program is working at almost 100% of those patients that were HIV positive on treatment. So what we found is that overall HPV positivity in this cohort of women was 28.2%, almost 30%. HPV 16 was found in 53 cases, making up 17.2%. So if you remember our discussion in the colposcopy workshop, cervical cancer type HPV 16 is mostly the driver for precancer and cancer. We also looked at HPV 18 and or 45, which contributed almost 20%. So the 3 of them, 16, 18, and 45, contributed about almost 40% of women that were HPV positive. Co-infection between 16, 18, and 45 was found in 2.3% of women, and 60% of women had other high-risk HPV types. When we looked at HPV positive women, we found out actually the HPV positivity was much higher. It was around 42.4%. So as a rule of thumb, half of women that are HIV positive will be positive for HPV. Compare this to HIV negative women, 26% tested for any positive, which shows that being HIV infected is a very high risk for acquiring HPV and for having persistent HPV infection. Then somebody mentioned in the morning that there's no point in doing screening if you're not bringing these patients for treatment. So I wanted to find out how many women were actually coming up for follow-up in colposcopy. So colposcopy attendance was 83.1%. We lost about 17%, and a lot of the patients that we lost were coming from Epworth. They were commercial sex workers. So they didn't want to come for the biopsy because they would be spotting for some few days, and that would lead to loss of business. So that was a big problem. So we ended up excluding commercial sex workers. And attendance among HIV positive women, which are women that have got a 6 times higher risk of having cervical cancer, was encouraging. Almost 80% of them came for treatment. We identified 62 CIN2 cases out of all those women that were HPV positive. I think I want to come and focus a little bit on the importance of histopathology. So initially, we were really surprised. We're not picking up any CIN2 plus cases. But we're saying with HIV and HPV, how come we're not picking up CIN2 cases? Eventually, WHO brought in an external reviewer, and we're able to pick up half of cervical of HCU that had been missed by local pathologists. And I think one of the things that we talked in the cervical cancer in the colposcopy workshop was the use of P16. I think we should be using more and more of P16 because our pathologists, I won't say this outside, but our pathologists are missing a lot of CIN2 plus cases. And if you look at women that were HIV positive, about 8% of them had CIN2 plus. So I think in a nutshell, HPV-16 is a key driver of severity. It was detected in 20% of CIN2 cases and 35% of CIN3 cases. What you also know is that other high-risk HPV types are highly prevalent in precancer, contributing about 60% of CIN2 and 47% of CIN3. HPV 18 and 45 plays a significant role in cancer, detected in 15.4% of CIN2, 8.8% of CIN3, and 50% of invasive cancers. But the co-infections with 16, 18, and 45 are not as common, and pattern is consistent. A similar genotype distribution was also observed in HIV negative women. So one of the things that is very important, that's why I acknowledge the colposcopists. We trained those registrars that I acknowledged on one of the slides. Because for you to train in an artificial intelligence platform, you need good images. So one of the outcomes of this study was to look at the quality of our images. So I'll just consider, if you look at the image focus, I think with 88% of the focus was good. If you look at brightness, not low, not too low, almost 100% of our patients, the pictures at appropriate brightness. If you look at brightness, not excessive, almost 100% of our patients. So there were minor problems with leaving a bit of discharge on the cervix looking a little bit sideways, but WHO was very, very impressed with the quality of the images that came out of Zimbabwe, way, way better than what they were getting in Thailand and India. So we are currently now training the artificial intelligence platforms, all those images, combining those from Thailand, India, as well as one of the criticisms was cervical cancer is more common in Africa. There were no images from African women. We didn't have HPV data from African women. And I think we just have been able to provide that to further train this artificial intelligence platform. We achieved an 82% concordance with spectroscopy. So in our phase 2, we're going to be also using a spectroscopy for HPV testing. And we noted that just by initial analysis of the data that I didn't present, AI model could achieve sensitivity and specificity exceeding 80% to triage HPV positive women. And further training of the AI algorithms to detect HPV on spectral images and neoplastic lesions on cervical is still ongoing. We are still continuously training and making that algorithm, system better. So enrollment for phase 2 has started in September 2025 and expected to run for 30 months. So we still have got a bit of time before I can be able to come back on this platform and say, ladies and gentlemen, we're now in that future where you walk into a clinic within 1 minute, you got a HPV result from spectroscopy, and then you walk into a clinic, where an artificial intelligence platform will tell you your diagnosis, will tell the practitioner that you've got a type 1, type 2, or type 3 transformation zone. The artificial intelligence platform will be able to suggest a treatment, ablation, or LEAP. So in conclusion, I want to say that by integrating non-invasive urine HPV detection, AI-based cervical imaging, and portable thermal ablation, the EASTER study aims to establish a cost-effective, single-visit model for screening, triage, and treatment. And EASTER project innovations represent a comprehensive solution for cervical cancer screening in low and middle income countries. This is a picture of all the people that are involved in the study when we did our initial protocol training here in Harare. I think you can see some familiar faces. Thank you very much for taking time to listen to my presentation.